With that, I'd like to introduce Dr. Alex Coe, who comes to us from Cedars-Sinai Medical Center. Alex is the medical director of liver transplantation, and so we're anxious to hear his discussion of the abstracts that were presented at this year's meeting. Alex?
Well, good morning, everybody. So that was an impressive tour de force through all the fatty liver abstracts. I think if Mazen's presentation was a ride with Paul in the Ferrari, my presentation is going to be maybe a bicycle ride with Paul through the liver transplant abstract. So a fewer abstracts, but maybe a little bit more in depth on each one. So there were a few themes at this year's liver meeting in regards to liver transplant, and I picked a few of them that are listed here, and so there are going to be about 5 or 6 abstracts that we'll go through. So the first one of 2 is one looking at donor quality, really focused on donor hepatic steatosis. And this is from the group at Cedars-Sinai, looking at the outcomes of using donor grafts with macrosteatosis defined as steatosis more than 30%. Historically, the use of these grafts are associated with increased risk for ischemia, reperfusion injury, primary non-function, and delayed graft function. And so the use of these grafts was quite selective in which recipients you might consider using these for. The group used the OPTN database, all deceased donor transplants over a 9-year period. They divided the recipients into donor livers that received a liver biopsy versus donor livers that did not receive a biopsy. And they stratified their analysis based on low versus high MELD in the recipients, where the cutoff was a MELD score of 33 or above, denoting the high MELD group. Their primary outcome was graft survival. And what this shows is the donor characteristics in the group that received a biopsy, the donor livers that received the biopsy versus the donor livers that were used that did not receive a biopsy, and a few sort of trends are evident. As expected, the group that received the biopsy were older, 50 versus 38 years in age. They had higher BMIs, and they had more metabolic risk factors like diabetes, hypertension. They're more likely to be hepatitis C positive, Hep B positive. In the recipients of the patients that received the donor livers that received biopsies, there were also some notable differences. Importantly, the MELD score was slightly lower in this population, 21 versus 23 MELD at transplant. And these patients were slightly less sick. So lower rates of encephalopathy, lower rates of ascites, lower rates of being on dialysis, lower rates of requiring ventilatory support, which you'd expect because these are going to be higher risk organs, and you might pass on using them for sicker patients. If you look at all of the donor livers that received biopsied and you broke them down into a degree of macrosteatosis, this is 40 to 50, 50 to 60, and above 60%, there are a few trends that stand out as well. With increased degrees of steatosis, the BMI goes up slightly as expected, but interestingly, there are lower rates of diabetes and hypertension. There are lower rates of being Hep C positive, which probably speaks to the centers trying to modify the risk using a steatotic liver by controlling for other factors that might decrease the risk of non-function or delayed graft function. If you look at the characteristics of the recipients of these organs, there were no significant differences. And so really the modification of the risk was happening on the donor side, not on the recipient side. So the next 2 slides are the key results. If you look at the graft survival of the donor livers that were transplanted that did not require biopsy compared to the donor livers that had steatosis up to 50%, there was no difference in survival in low MELD patients. So these are patients with MELD scores below 33. However, there was a drop in graft survival if the amount of steatosis exceeded 50%. If you then look at the high MELD patients, MELD scores 33 and above, that cutoff in decrease in survival really happened at slightly lower degree of steatosis at 40%. And so it seems like you can get away with using a donor liver with up to 40% steatosis in the MELD score patients above 33, whereas in the low MELD patients, you can go up as high as 50%. And that's what their conclusion was. The lower MELD recipients had no difference in one-year graft survival up to 50% macrosteatosis, whereas in the higher MELD patients, there was no difference in one-year graft survival up to 40%. Moving on to the next abstract, the group from Hopkins looked at the trends in utilization of macrosteatotic donors in the United States over a 12-year period. They defined steatotic donor livers as donor livers that had more than 30% macrosteatosis. And what they reported was there's been a trend in increased utilization of these organs. And so discard rates in 2005 was 58%. By 2017, the discard rate had fallen to 43%. And if you look at each of these time intervals, the adjusted odds ratio for discard has been falling. But in the most recent cohort, 2015 to 2017, there was still an odds ratio of nearly 9 for discarding these organs. An interesting finding was that there was a difference in patient survival in utilizing these organs that was different by era. And so if you look at the era between 2005 and 2011, the use of these macrosteatotic livers led to an increased mortality in these patients. But if you look at the most recent era, 2012-2017, there was no difference in survival in recipients of macrosteatotic donor livers versus less than 30% steatosis. So it looks like perhaps that post-transplant outcomes using these macrosteatotic livers have improved over time and are actually equivalent to the outcomes with non-macrosteatotic livers in the most recent era. But despite this, the discard rate was 9-fold higher in the macrosteatotic livers, although that discard rate has gone down over time. Now moving on to a topic that generated considerable controversy, a lot of interest and discussion at several sessions at AASLD. This is the report from the Mayo Group. All 3 centers participated in the study, although the only patients that underwent transplant in this cohort were the Rochester and the Jacksonville centers. But this is a study looking at the experience of using Hep C positive donor livers and transplanting them into Hep C negative recipients. So this was a retrospective analysis of a prospectively collected cohort. They started as an IRB-approved study that evolved into clinical practice protocol as their standard of care. The inclusion criteria included adult transplant recipients, MELD score between 10 and 34, that were not candidates for live donor transplant. The donors had to have no history of failed Hep C therapy. They could be hepatitis B core antibody positive but not negative. And if they underwent a liver biopsy, they could not have greater than stage 2 fibrosis on that biopsy. This is their DA treatment regimen slide. I think this speaks to the heterogeneity of these different treatment protocols, sort of speaks to the fact that this was a retrospective analysis. So here's sort of the meat of this. There were 40 donor grafts from Hep C seropositive donors. Of those, 26 were NAT positive, so PCR positive. 12 of those NAT positive donors went into Hep C positive recipients. 14 of these NAT positive donors went into Hep C negative recipients. So we'll focus on those 14 patients. The authors wanted to highlight that these were complex patients. 29% of these transplants were from DCD donors, 21% combined liver kidney, and 17% were retransplanted patients. The median wait time for these patients before enrolling in this protocol was 60 days, and after enrolling in this protocol, the median wait time to transplant was 65 days. So all of the recipients of serologic positive NAT negative grafts remained PCR negative on follow-up. In the 14 patients that received the NAT positive grafts that were Hep C negative, all of them were viremic within 5 days after transplant, with a mean viral load that was quite high. We're looking at 10 to the 7th IUs per ml. And the median time to start DA therapy was nearly 28 days. So fortunately, all patients that were viremic post-transplant achieved SVR12 with therapy. Their adverse event rates here are listed. A little bit hard to know what to make of it without a control group, but biopsy-proven acute rejection in 17%, and one patient had renal failure. And this is that renal failure patient that I wanted to highlight. This was a 61-year-old man with diabetes and NASH cirrhosis, received a NAT-positive donor liver, was viremic post-op day 1, developed Hep C-related membranous nephropathy, required dialysis, eventually was treated with DA therapy and achieved SVR12, was able to get off dialysis, but within 9 months had an episode of acute kidney injury, was restarted on dialysis, and this patient eventually expired. The authors mentioned they thought the death was related to the renal failure. So the author's conclusion was that liver transplant using Hep C seropositive grafts into Hep C seronegative recipients resulted in excellent short-term outcomes. Now, I think this generated a number of questions. I think the key themes at the liver meeting were what is the best strategy to deal with Hep C viremia after transplant? This group and many others that have published their results favored a test and treat strategy. You wait until they're viremic, and then you request approval to start DA therapy versus a preemptive therapy, which would be to start therapy possibly on the way to the OR to minimize the risk of exposure to virus. I think we need to develop strategies to address the delays in insurance authorization for DA therapy, again, to minimize the risk to our patients. And I don't think we really don't know what the long and short-term risk of the extrahepatic complications of Hep C virus exposure really is. I think the case of the membranous nephropathy reported in this Mayo abstract sort of illustrates that point nicely. So moving on to another very controversial topic in our field, which is early transplant for patients with alcoholic hepatitis. This abstract really looked to see were there any predictors in different patterns of alcohol use after transplant, utilizing the Accelerate AH cohort. And this is a cohort of 11 centers representing 8 different UNOS regions. They retrospectively looked at patients that received transplant with less than 6 months sobriety that had alcoholic hepatitis. And what they reported was that recipients of these transplants were asked about alcohol use at every post-transplant visit. 10 out of the 11 centers used alcohol biomarkers, most commonly urine ethylglucuronide and serum phosphatidylethanol. 6 of the centers did it routinely and 4 did it intermittently. Alcohol used after transplant was categorized based on the NIAAA definitions. Binge drinking in men is 5 or more drinks within 24 hours, In women, 4 or more drinks within 24 hours. And frequent drinking was defined as 4 or more drinking days within 1 week. And with these definitions, they broke down the relapse categories into non-complete abstinence, non-binge, non-frequent drinking, binge or binge and frequent. This is the sort of table 1 of the 153 recipients of early transplant for ALK-HEP. They were young. A median age was 42, largely Caucasian. Very high MELD scores, as you would expect at the time of transplant at 37. Half of them had at least grade 2 encephalopathy. And the median number of days of alcohol absence before transplant was only 53. And this is what they found was the pattern of drinking with up to 5 years of follow-up. So most commonly, 70% of these patients remained abstinent up to 5 years. 6% of these patients had late but non-heavy alcohol use. 15% had early but non-heavy alcohol use. And 8% had early and heavy alcohol use after transplant. They tried to look at predictors. How can we predict which patients are going to have problematic patterns of drinking after transplant? And they looked at a few factors. If they had any history of alcohol-related legal problems like DUI, if they'd had a history of multiple failed rehab attempts, if they had overt encephalopathy at the time of transplant, and also the age of the recipient. And they found that the best predictors of early but non-heavy alcohol use were the presence of multiple failed rehab attempts and the presence of overt encephalopathy. Whereas early and heavy use, the best predictor was young age. And so if the age was less than 43, those patients had a much higher risk of early and heavy use. Now, in the past, we'd often thought of relapse to alcohol after transplant as, well, maybe it's not such a big deal. Maybe as long as they keep taking the immune suppression, as long as they're following up in clinic, the liver's going to be okay. But what this study shows is that's actually not the case in some of our patients. It really depends on what their pattern of use is. If they have the early but non-heavy pattern or the early and heavy pattern, yes, they do fine in the first year, but their survival at year 3 and year 5 drops significantly. So what can we conclude from this? We could probably conclude that we can stratify patients at higher risk of problematic drinking patterns after transplant. And these patients probably should be targeted for intensive surveillance and linkage to treatment for the alcohol use disorder, especially in that first 6 months. And these are recipients younger than 43 years, have history of multiple failed rehab attempts, and definitely patients that had encephalopathy at the time of transplant. And this slide just sort of reiterates that. The last abstract that I want to cover is an interesting concept in trying to figure out, are there non-invasive ways that we can predict acute cellular rejection after transplant? And this was a study presented by Josh Levitsky with many collaborators at several centers. They developed a unique a blood genomic signature that could predict rejection. And what they did was they developed 2 cohorts of patients. They ran this genomic signature test at serial intervals. And in patients that ended up having biopsy-proven rejection, they could show that the change in the genomic profile, even 100 days before the biopsy showed rejection, was showing a trend that this patient was at risk for developing biopsy-proven rejection. Whereas if your profile did not meet the threshold for concern for rejection, it was unlikely that those patients ever developed rejection. If you look at the performance characteristics of their assay, the positive predictive value was not very good. It was a coin flip, 50-50. But the negative predictive value was pretty decent, 0.87, 0.95. And the way I think about this is, potentially you could use an assay like this to help you personalize your dosing of immune suppression. For instance, if it looks like the trend looks non-concerning for rejection, you might be able to continue to wean the dose of your CNI. But if it looks like the trend is starting to go up, maybe you've reached that threshold where you might not be able to wean that patient's immune suppression any longer. So we only touched on 5 or 6 abstracts, but this slide deck these slides are available for you, but these are a number of other abstracts which I thought were quite interesting that if you do have time, I do encourage you to review. And so we reached the end of our bicycle tour of liver transplant abstracts for the AASLD meeting. Thank you.